The AKI Care Bundle should be instituted in all patients with AKI. These are patients with a 1.5-fold acute rise in serum creatinine or 6 hours of oliguria. A full set of physiological observations should be performed. Most hospitals have physiological multiple early warning or MUSE systems in place. If a patient is MUSE triggering, the critical care outreach team should be contacted urgently. The circulatory status of the patients should be assessed. This should include measurement of heart rate and blood pressure. The patient's peripheral perfusion should be assessed and the capillary refill time measured. The patient should be examined for signs of dehydration, and the jugular venous pressure should be estimated clinically. Some patients with acute kidney injury will be fluid overloaded, and it is important to examine for signs of pulmonary or peripheral edema. If the patient is hypovolemic, fluid should be given as a bolus of resuscitation fluid. National guidelines recommend the administration of a colloid or balanced crystalloid for resuscitation. Balanced crystalloids, such as Hartmann's solution, do contain potassium and should only be used with careful monitoring in AKI. When fluid is administered for resuscitation in AKI, it is critical that the response to fluids is reassessed by checking the physiological observations and repeating the clinical examination. Once the patient is fluid replete, maintenance fluids should be given. In general, these are estimated outputs, plus around 500 ml for insensible losses. This is usually given orally or as intravenous crystalloids. Monitoring in AKI is critical. This should include ongoing physiological observations, fluids charts, daily weights, and regular clinical assessments of the fluid status. Catheterization and measurement of hourly urine volumes may be beneficial in some patients. Blood tests for urea, creatinine, bone biochemistry, and venous bicarbonate should be performed twice daily if the creatinine is rising. If the venous bicarbonate is low or the patient is hypoperfused, arterial blood gases, including measurements of serum lactate, should be performed. Unless the cause of AKI is readily apparent, this condition should be investigated. A urine dipstick should be performed. Heavy blood and protein on urine dipstick may be a marker of treatable parenchymal renal disease, such as glomerulonephritis. A renal ultrasound should be performed in all patients with AKI which is not recovering and where the cause is not clear. Ultrasound will exclude most forms of obstructive AKI and will give important information of renal size. If obstruction with urinary sepsis or pyonephrosis is suspected, ultrasound should be performed within 6 hours, as such cases require immediate relief of obstruction to prevent worsening sepsis. Important blood tests which are rapidly available for investigation of AKI are shown here. Appropriate supportive care of the AKI patient is critical. If there is severe sepsis, intravenous antibiotics should be administered immediately. Drug prescription should be reviewed. Iodinated radiological contrast should be avoided if possible, but if necessary, contrast prophylaxis should be given. The AKI Care Bundle is summarised in the clinical section of www.londonaki.net. Please also download our iPhone app to use the bundle, and also refer to the clinical section of the website for guidelines on the management of AKI complications, AKI referral, and safe transfer. Educational materials are also available on the Academy pages of our website.